So the final topic for this evening is depression, which, as many of you know, is a very significant mental health concern worldwide. The chances of any of us having a significant episode of depression during our lifetime are 1 in 2. And depression is the major cause of morbidity worldwide. In other words, depression causes more impairment than diseases such as heart disease, cancer, or diabetes. And people with ASD are not protected from developing depression, so we need to be alert to its possibility. And as in the rest of the population, the risk of developing depression increases really quite dramatically around the time of puberty. So the factors that can contribute to depression can be thought of in terms of those that are related to the child's autism and those that would be general risk factors in the population. So many individuals post-puberty are often socially isolated, may not have friends at high school, or worse, may be actively rejected or teased or bullied by their peers, which can lead to low self-esteem. Additionally, more able individuals may become increasingly aware of the differences between themselves and typically developing individuals, and that's usually associated with negative cognitions. And as Melanie pointed out, quite often children in the educational setting may not be receiving the supports that they need to function at the same level as their peers, and may be consistently getting poor grades or told to repeat assignments. We know that individuals who suffer with epilepsy, which affects about 20% of people with ASD, are at increased risk for all psychiatric disorders, including epilepsy. And finally, if you're suffering dreadfully with anxiety or confined to your house and handicapped by OCD, that also has a knock-on effect on one's mood. Now, common things that can lead any of us to be depressed are negative life events. So we accept that grief is a modified form of depression, which in some cases can turn into a full-blown clinical disorder, but parents separate and divorce, siblings who a child may be very close to may move away either for college or work, individuals may be involved in accidents. The usual run of things that we know can negatively impact on people's mood have the same effect in people with ASD. Physical illnesses can also precipitate an episode of depression, particularly viral illnesses or things that lead to prolonged hospitalization. And lastly, and particularly importantly, in the general population and in families with ASD, depression runs in families. The risk for developing depression is strongly mediated by genetic factors, and therefore it's very important that when we're assessing children for possibility of depression that we take a good family history, and particularly important that we identify anyone who has elevated mood, in other words, has bipolar disorder, because it's possible that the child may also be susceptible to bipolar, and that requires some caution if we're going to start the child on antidepressant medication. Now, in very able children, there may be no difficulty at all in picking up depression, because the child or youth may articulate how they're feeling in the same way as a typically developing child. The problem comes when the individual has less insight into their emotions, or possibly has limited or no language skills and is not able to convey how they're feeling. So sometimes depressed individuals don't complain that they're feeling depressed. They're possibly just going to say they're miserable or fed up. Clearly, some individuals will be expressing suicidal thoughts, but a particular and unusual issue for dealing with ASD is that occasionally one sees patients who have had a preoccupation with death and suicide for very many years. And then on top of this autistic preoccupation, there's a sudden ramping up in the severity of this thinking if the person is also depressed. Parents tend to be pretty good at recognizing when their offspring are depressed and will generally notice if they're not enjoying things that usually give them pleasure, if their concentration has dropped off, if they're showing unusual lack of energy, or, and quite commonly in children, complaining of physical aches and pains or just generally feeling under the weather. In addition to negative cognitions, people may complain that they're feeling bad about themselves, not worthy, may be negative about the future and hopeless about how they will fare, wondering whether they will ever be employed or succeed academically, might be blaming themselves for things that have happened in the past that actually weren't their fault. And other people may notice that the person's thinking just seems to have slowed down a tad compared to usual, and they're having trouble concentrating, perhaps particularly in the school environment. And in non-verbal individuals, we're having to pay attention to what the individual is doing rather than saying. So the individual may be withdrawing themselves, spending more time in their room, avoiding being with their family, not experiencing pleasure, maybe irritable or sometimes aggressive, showing overall decreased activity, in other words, sitting around, not moving as much as they normally do. Or depression may show itself as does severe anxiety by an increase in stereotyped behavior. And if depression becomes quite severe, then we might start to see patterns that we see in the typically developing population in terms of mood being worse first thing in the morning, so that people are less active first thing and get more energetic as the day goes on, or more irritable first thing in the morning. And if we're depressed for long enough, it can interfere with our sleep, eventually appetite, and therefore, of course, we might tend to lose or gain weight. In terms of treatment, it's important that we remedy any of those etiological factors that I mentioned, particularly those that show a strong association with autism. So if the child is socially isolated, what can we be doing to teach the individual social skills or help introduce them to people that they may form friendships with? Are there things we can be doing in terms of ensuring better academic success? Can we be starting to talk to the individual about realistic plans for the future and making sure that they understand that for most individuals, high school is perhaps the most difficult and trying time in one's life, and that when one leaves high school, people often tend to be a little bit nicer to us. Now, you've heard about the main treatments, which of course are again CBT and SSRIs. It's best to start with modifying the environment, and then if the child is amenable to CBT, there are versions of CBT that particularly focus on negative cognitions and catastrophic thinking, and as Melanie pointed out, one needs to play to the behavioral aspects of CBT and particularly harness any of the idiosyncrasies of the individual that may help with treatment. SSRIs are as effective in treating depression in individuals with ASD as they are in the rest of the population. Obviously, we have to monitor carefully in those individuals who have suicidal thoughts to make sure that accidentally we're not increasing risk when people are going through a period when they're more energized because of SSRIs, but have still not got normalized mood. And in families where there's a history of elevated mood as well, some clinicians would choose to also start the child on a mood stabilizer, either just before an antidepressant or at the same time, just to reduce the risk of inadvertently causing elevated mood. So in many ways, identifying and treating depression is perhaps the simplest of the disorders that we've heard about today. But as in the general population, if you're prone to depression, it means there's a likelihood that you will develop it again in the future, and therefore making sure that people are really attending to the environmental factors that are remedial is very important. So we're now going to hand over to our two panelists, and I assume that Georgina is going first.